Welcome to our review of clinical laboratory tests and diagnostic procedures for the Neonatal Nursing Certification Exam. Today we'll cover the essentials you need to know for the exam, with special attention to high-yield topics that appear frequently on the test. Here's what we'll cover in today's session. We'll start with laboratory interpretation principles, the foundation of clinical decision-making. Then we'll examine the most important diagnostic studies and imaging techniques. We'll review common procedures you'll need to understand for the exam, and finally, we'll look at equipment and monitoring techniques. Before we dive in, let's talk about how this material appears on the exam. The certification test isn't looking for simple recall. Instead, you'll see application and analysis questions that require you to interpret results and connect them to clinical scenarios. Common question types include identifying the next best test for a clinical presentation, interpreting lab results, distinguishing normal from abnormal findings, recognizing radiographic patterns, and understanding proper equipment placement. Questions often present a scenario and ask, what do these findings suggest? Or, what is the next appropriate action? Let's start with a concept that underlies everything in this section: judicious use of laboratory testing. In neonatology, we must be extremely thoughtful about every test we order. Before getting any lab, consider, is it clinically necessary? Will it change management? Is this the best test to answer our clinical question? What are the blood volume requirements, and do the benefits outweigh the risks? Is the timing appropriate? Will the results contribute to the diagnosis or immediate management? Remember, neonates have limited blood volume, so every milliliter counts. Understanding sample types is fundamental. Whole blood contains all components: red cells, white cells, and platelets suspended in plasma. Plasma is what's left after removing blood cells by centrifugation, and it still contains fibrinogen. Serum is plasma without clotting factors. For neonates, remember they have a limited blood volume of only 80 to 100 milliliter per kilogram. This means a 1 kilogram infant has just 80 to 100 milliliter of total blood volume. Also important to know is that capillary samples can differ significantly from central samples. For example, capillary heel stick samples tend to have higher potassium levels due to hemolysis, and capillary hematocrit readings run about 10% higher than central values. This is tested frequently, so remember when to confirm with central samples. To start, you have to know the normal electrolyte values. This is required, so memorize them. Sodium runs 135 to 145, potassium is 3.5 to 5.5, total calcium is 8.5 to 10.2, while ionized calcium, the physiologically active form, should be 4.4 to 5.3. Magnesium ranges from 1.5 to 2.5. Phosphorus in neonates is higher than adults at 6.5 to 7. And bicarbonate should be between 22 to 26. These ranges are high yield content. Examiners love to test whether you know when values fall outside these parameters and what clinical implications might follow. Sodium abnormalities are frequently tested on the exam. Hyponatremia, defined as sodium less than 130, presents with irritability, seizures, poor feeding, and poor growth. Common causes include fluid overload, diuretics, SIADH, and excessive free water intake. Hypernatremia, sodium greater than 150, presents with irritability, high-pitched cry, and hyperreflexia. It's typically caused by dehydration, inadequate water intake, or diabetes insipidus. A key concept to remember is that sodium abnormalities often reflect water balance problems rather than actual sodium excess or deficit. The exam frequently tests your ability to distinguish between the two. Potassium disorders may affect cardiac function. Hypokalemia, potassium less than 3.5, presents with hypotonia, ileus, and cardiac arrhythmias. On ECG, you'll see flattened T waves, U waves, and prolonged PR intervals. Hyperkalemia, potassium greater than 6, is potentially life-threatening. The earliest ECG change is peaked T waves. This is a classic board exam question. As hyperkalemia worsens, you'll see widened QRS complexes and ventricular arrhythmias. Treatment is another high-yield topic. Calcium gluconate to stabilize cardiac membranes, albuterol for temporary shifting of potassium intracellularly, insulin with glucose to promote cellular uptake, and sodium bicarbonate in acidosis. Calcium abnormalities may appear on the exam. Hypocalcemia is common in at-risk neonates, including preterm infants, infants of diabetic mothers, and those with birth asphyxia. Clinically, you'll see jitteriness, seizures, apnea, and tetany. The ECG shows a prolonged QT interval. Treatment requires calcium administration with mandatory cardiac monitoring. The exam often tests this safety point. Hypercalcemia is less common, but presents with lethargy, poor feeding, and hypotonia. It's associated with subcutaneous fat necrosis. Remember that total calcium levels can be misleading in the setting of hypoalbuminemia. Ionized calcium is the gold standard measurement in these cases. Let's review key metabolites. Bilirubin is a breakdown product of heme. Direct or conjugated bilirubin is abnormal if it's greater than 2.0 milligrams per deciliter or more than 20% of the total. Indirect or unconjugated bilirubin is fat-soluble and can cross the blood-brain barrier, leading to kernicterus. Blood urea nitrogen normally ranges from 5 to 25 milligrams per deciliter and reflects both renal function and protein metabolism. Creatinine is a bit tricky in neonates. It initially reflects maternal values and then decreases over the first week. In preterm infants, creatinine actually rises in the first 48 hours before falling. Liver function tests are important to understand. Alkaline phosphatase typically ranges from 150 to 420 in neonates. When levels exceed 500 to 700 milligrams per deciliter, it suggests bone disease like rickets. Alanine aminotransferase, ALT, previously called SGPT, is more specific for liver disease than AST. ALT elevation is particularly important in herpes simplex virus infection. Aspartate aminotransferase, AST, previously known as SGOT, is less specific for liver disease since it's also found in heart and muscle tissue. The ALT-AST ratio helps differentiate types of liver disease, with alcoholic liver disease typically showing an AST ratio greater than 2:1, though this is less relevant in neonates. Therapeutic drug monitoring is essential for optimizing medication therapy in neonates. The exam tests your knowledge of common monitored drugs, like antibiotics, which require peak and trough levels. Caffeine citrate has a therapeutic range of 5 to 25, phenobarbital ranges from 15 to 40, and digoxin should be maintained between 0.8 to 2.0. For toxicology screening, know that urine gives the most immediate results, but only detects recent exposure. Meconium testing provides longer historical data since it accumulates throughout pregnancy. Hematologic tests are fundamental in neonatal care. Normal values differ significantly from adults and vary by gestational age. For term infants, hemoglobin typically ranges from 16 to 20, while hematocrit runs between 48 to 60%. These values are higher at birth and decrease over the first week of life. Platelet counts should be between 150,000 to 400,000. White blood cell counts in neonates run higher than in adults, ranging from 9,000 to 32,000 at birth. It's important to know these normal ranges to recognize when values fall outside parameters. The exam will probably test whether you can distinguish between normal transitional changes and pathologic findings. The white blood cell differential is a frequently tested topic. You need to know how to calculate the absolute neutrophil count using this formula. Neutropenia, defined as ANC less than 1,500, is the most accurate predictor of infection. Another critical calculation is the I to T ratio, which is the immature to total neutrophil ratio. It's calculated as the percentage of bands plus immature forms divided by the percentage of mature neutrophils plus bands plus immature forms. This ratio is maximum at birth and decreases to 0.12 after 72 hours. An I to T ratio over 0.2 suggests infection with 90% sensitivity. These calculations appear frequently on the exam, often as part of case scenarios. Coagulation studies are important to understand for the exam. Fibrinogen, or factor 1, is typically low in disseminated intravascular coagulation. Prothrombin time measures the extrinsic pathway, while activated partial thromboplastin time evaluates the intrinsic pathway. International Normalized Ratio is a standardized way to report PT. D-dimer is elevated in thrombotic events. A key concept for the exam is that coagulation values in neonates differ from adults. Premature infants normally have prolonged PT and APTT values compared to adults, but this doesn't necessarily indicate a bleeding disorder. The exam often tests whether you can distinguish between normal neonatal values and truly pathologic findings. Microbiology tests are critical for diagnosing infections. Most blood cultures require a minimum of 1 ml of blood for adequate detection of bacteremia. However, some newer blood culture products can go a bit lower. Ideally, blood cultures should be collected before antibiotics are started, though in critically ill neonates, treatment shouldn't be delayed for culture collection. CSF cultures are essential when evaluating for meningitis, and urine cultures help diagnose urinary tract infections. Viral studies may include PCR, culture, or serology, depending on the suspected pathogen. Remember that in neonates, the inflammatory response may be blunted, making clinical signs of infection subtle and laboratory diagnosis even more important. On the exam, you will probably have a question presenting an infant with an infection, and you'll need to determine which microbiologic test would be appropriate. Immunologic tests frequently appear on the exam. C-reactive protein is an acute phase reactant that rises 6 to 8 hours after infection begins. It has relatively low sensitivity, about 60% initially, but sensitivity improves at 24 to 48 hours. CRP is most useful for monitoring treatment response rather than initial diagnosis. Procalcitonin rises faster than CRP, starting at 4 hours and peaking at 6 hours after infection onset. It has higher sensitivity and specificity than CRP for bacterial infections. The exam often tests the relative utility of these inflammatory markers, asking which is most appropriate in different clinical scenarios. Remember that serial measurements are more valuable than single values, especially for monitoring treatment response. Blood bank tests are important for diagnosing hemolytic diseases and planning transfusions. Standard blood typing identifies A, B, O, and Rh status. The direct antiglobulin test, also called the direct Coombs test, is positive when maternal IgG antibodies are bound to the infant's red blood cells. The indirect antiglobulin test is positive when antibodies against the infant's red cells are present in maternal serum. The Kleihauer-Betke test identifies fetal hemoglobin in maternal blood and is used to quantify fetal-maternal hemorrhage. This test helps calculate the appropriate dose of Rh immunoglobulin, RhoGAM, to prevent sensitization. The exam frequently tests your understanding of these immunohematologic concepts, particularly in cases of hemolytic disease of the newborn. Let's move to radiography, which is one of the most heavily tested areas on the exam. Basic radiographic principles include understanding that air appears black on X-rays, while fluid and tissue appear white or gray. You should know common views. The anteroposterior, or AP view, is taken with the infant supine, and the beam directed from front to back. The cross-table lateral view is taken with the infant supine and the beam directed from the side. The lateral decubitus view, with the infant positioned on one side, is particularly useful for assessing free air in the abdomen. A right lateral decubitus position, left side up, is best for seeing pneumoperitoneum because free air rises to the right upper quadrant where it's easily visualized above the liver. You may see a question asking you to identify which type of X-ray would be best for evaluating an infant with some given clinical picture. You should be familiar with radiographic terminology, as questions may either present an X-ray or give you a verbal description of the X-ray findings. Density refers to how tissues appear on X-rays. Air is radiolucent, black, while bone is radiopaque, white. Fat, water/soft tissue, and metal each have distinct densities. Exposure affects image quality. Underexposed films appear light and hazy, making it difficult to see details. Overexposed films are too dark and lack contrast. Radiolucent structures allow X-rays to pass through and appear dark on films, while radiopaque structures block X-rays and appear white. Rotation is another important concept. It affects visualization of structures and can be assessed by comparing rib lengths on either side of the chest. In a properly positioned AP film, the ribs should appear symmetrical. A systematic approach to chest X-ray interpretation is useful for clinical practice. The alphabetic method is a helpful way to ensure you don't miss anything. Start with A for airway. Check endotracheal placement and tracheal position. B for bones. Examine ribs, clavicles, and vertebrae for fractures or abnormalities. C for cardiac structures. Assess heart size and shape. D for diaphragm. Look at contour and position. E for effusions. Check for pleural fluid. F for fields and fissures. Examine lung fields for infiltrates or consolidation. G for gastric fundus. Confirm it's in the correct position. And H for hilum and mediastinum. Look for lymphadenopathy or widening. The exam typically describes radiographic findings and asks you to recognize what condition they're associated with, so having a systematic approach is crucial. Radiographic patterns in respiratory disease are extremely high yield for the exam. Respiratory distress syndrome has a classic appearance, and you will probably see a question asking about recognizing it. The three classic findings are a diffuse reticulogranular pattern, often described as ground glass appearance. Air bronchograms are visible as dark branching structures against the white background of consolidated lung. Overall lung volumes appear decreased. These findings reflect diffuse atelectasis due to surfactant deficiency, and transient tachypnea of the newborn has distinct radiographic features that differ from RDS. You'll see bilateral diffuse haziness with fluid in the horizontal fissures. Perihilar streakiness is common, along with hyperinflation that's more prominent at the periphery. Unlike RDS, the haziness in TTN clears from the periphery inward. This reflects the different pathophysiology. TTN results from delayed clearance of fetal lung fluid rather than surfactant deficiency. The course is typically benign with clearing within 24 to 72 hours. Being able to distinguish TTN from RDS radiographically is a frequently tested concept, so focus on these distinguishing features. Meconium aspiration syndrome presents with a distinctive radiographic pattern of coarse, irregular lung markings with areas of hyperinflation alternating with areas of consolidation. This creates a patchy, asymmetric appearance. The hyperinflation occurs from ball valve obstruction, where meconium allows air in but not out during respiration. Consolidation areas represent atelectasis or pneumonia. Unlike RDS, which affects premature infants, MAS typically occurs in term or post-term infants with a history of meconium-stained amniotic fluid. The combination of hyperinflation and patchy infiltrates is the key radiographic feature that distinguishes MAS from other neonatal respiratory conditions. Many gastrointestinal conditions have characteristic radiographic findings. Duodenal atresia presents with the classic double bubble sign, two adjacent air-filled structures representing the dilated stomach and proximal duodenum. This condition is associated with polyhydramnios prenatally and is more common in infants with Down syndrome. These associations may appear on the exam. Necrotizing enterocolitis has several radiographic hallmarks. Pneumatosis intestinalis, air in the bowel wall, appears as a bubbly or linear pattern along the intestinal wall. Portal venous gas indicates more severe disease. Pneumoperitoneum, free air in the abdomen, suggests intestinal perforation and is an indication for surgical intervention. The proper positioning of tubes and lines on X-ray is important for the exam and clinical practice. For endotracheal tubes, the tip should be in the mid-trachea between the second and fourth thoracic vertebrae. approximately 1 to 2 centimeters below the vocal cords and above the carina. For umbilical artery catheters, there are two acceptable positions: high position between T6 and T10, or low position at L3, L4. For umbilical venous catheters, proper placement is 0.5 to 2 centimeters above the diaphragm at T8 to T9, just below the junction of the inferior vena cava and right atrium. Exam questions either show an X-ray image or describe X-ray findings in text, asking you to assess tube positioning or identify potential complications from malposition. Continuing with lines and tubes, chest tube placement varies depending on what you're draining. For air evacuation, anterior placement is preferred since air rises anteriorly in the supine infant. For fluid drainage, posterior placement is more effective. For peripherally inserted central catheters, the tip location depends on the insertion site. For upper extremity PICCs, the tip should be in the superior vena cava. For lower extremity PICCs, the tip should be in the inferior vena cava. A helpful landmark is that the cavoatrial junction is approximately 2 vertebral bodies below the carina on an AP chest X-ray. Ultrasound is an important diagnostic tool in neonatology. It uses oscillating sound waves to evaluate tissue density, movement, and blood flow. The major benefits include no radiation exposure, real-time imaging capability, portability for bedside use, and no need for sedation. However, it does have limitations. It's operator-dependent, meaning the quality of the study depends on the skill of the person performing it. It's also limited by air interfaces, which block ultrasound transmission. The exam might test your understanding of when ultrasound is the preferred imaging modality and when its limitations necessitate alternative imaging approaches. Ultrasound applications are common in neonatology. For brain imaging, ultrasound is performed through the anterior fontanelle and is excellent for detecting intraventricular hemorrhage and areas of increased echogenicity. However, it's less sensitive than CT or MRI for subtle abnormalities. Cardiac ultrasound, or echocardiography, is the gold standard for diagnosing congenital heart disease. It allows visualization of cardiac structures and assessment of function. Renal ultrasound is the preferred initial study for evaluating the kidneys and urinary tract. Abdominal ultrasound helps assess liver, spleen, and other intra-abdominal structures. Vascular ultrasound can evaluate blood flow and assist with PICC line placement. The exam may ask which imaging modality is most appropriate for specific clinical scenarios. There are several types of echocardiography you should understand for the exam. Transthoracic echocardiography is the most common approach used in neonates. Transesophageal echocardiography is rarely used in neonates except during cardiac surgery. M-mode echocardiography provides a single-dimension view and is useful for evaluating cardiac valve motion and ventricular function. Color flow Doppler shows patterns of blood flow and helps identify restrictions or regurgitation. Continuous wave Doppler quantifies flow across valves and estimates pressure gradients. The exam often tests your knowledge of which echocardiographic technique is most useful for specific diagnostic questions, such as using color Doppler to evaluate a patent ductus arteriosus. Components tomography combines multiple X-ray images taken from different angles to create detailed cross-sectional images. CT can be enhanced with contrast agents to better visualize vascular structures. In neonatology, CT is particularly useful for identifying space-occupying lesions like congenital pulmonary airway malformation, bronchopulmonary sequestration, and congenital lobar emphysema. CT angiography helps diagnose pulmonary hypertension in infants with bronchopulmonary dysplasia. The main limitation is radiation exposure, which is a special concern in neonates. MRI uses radio waves rather than radiation to create detailed images, making it particularly valuable for neonates. It provides superior soft tissue detail compared to CT, and is the preferred modality for neuroimaging, especially for evaluating hypoxic ischemic encephalopathy, congenital brain malformations, and subtle white matter injuries. Despite these advantages, MRI has significant limitations in the NICU setting. It's expensive, time-consuming, usually requires anesthesia for adequate imaging, and has limited availability in many hospitals. The exam may ask about the appropriate use of MRI versus other imaging modalities, particularly for neurologic conditions where MRI's superior tissue contrast provides critical diagnostic information. Fluoroscopy produces real-time dynamic images using sequential X-rays, allowing visualization of motion. Common applications include upper GI series to evaluate the structure and function of the esophagus, stomach, and small intestine. This is the gold standard test for diagnosing malrotation with possible volvulus, a can't-miss diagnosis. Barium enema studies help diagnose Hirschsprung's disease and can be both diagnostic and therapeutic for meconium plug syndrome. Voiding cystourethrogram evaluates the urinary tract, particularly for vesicoureteral reflux and posterior urethral valves. The exam tests your knowledge of which fluoroscopic study is most appropriate for specific clinical presentations, such as bilious vomiting in a newborn, like an upper GI series for malrotation. The electroencephalogram measures brain electrical activity and is used in questions about neonatal seizures and encephalopathy. EEG interpretation focuses on three key elements: continuity of background activity, the most critical component, synchrony between hemispheres, and specific waveform patterns. There are two main types of EEG in neonatal care. Conventional EEG is the gold standard, providing comprehensive coverage of brain activity, but requiring skilled technicians and interpreters. Amplitude integrated EEG offers simplified, continuous bedside monitoring, but covers limited brain regions. The exam often tests the EEG patterns in hypoxic, ischemic, encephalopathy, where background patterns like burst suppression, continuous low voltage, and flat trace have prognostic significance. The electrocardiogram records the heart's electrical activity and is an essential tool in neonatal care. Standard lead placement includes left arm, LA, black electrode, right arm, RA, white electrode, and left leg, LL, red electrode. ECGs help diagnose arrhythmias, evaluate the effects of electrolyte imbalances, especially potassium, calcium, and magnesium, assess for myocardial ischemia, and identify ventricular hypertrophy. The exam may ask questions about ECG changes associated with electrolyte disorders, particularly hyperkalemia, peaked T waves, hypocalcemia, prolonged QT interval, and hyper/hypomagnesemia. Remember that neonatal ECGs normally show right ventricular dominance, unlike adults. The ability to recognize normal versus abnormal ECG patterns in neonates is a high-yield exam topic. Ventilatory support techniques begin with bag and mask ventilation, which is indicated for apnea, heart rate below 100 beats per minute, or persistent cyanosis despite supplemental oxygen. Proper mask size is crucial. It should cover the mouth and nose, but not the eyes to create an effective seal. There are three main types of resuscitation devices: self-inflating bags, which can be used without a gas supply, flow-inflating bags, which require a gas source but can deliver CPAP, and T-piece resuscitators, which provide consistent pressures and PEEP. The exam may test your knowledge of the advantages and limitations of each device, particularly that only self-inflating bags can function without a gas source. The laryngomask airway is an alternative airway device. It's particularly valuable in difficult airway scenarios like micrognathia or Pierre Robin's sequence, where visualization of the vocal cords may be challenging. It can also serve as a bridge to intubation or during flexible endoscopy. However, LMAs have important limitations you should know. They cannot be used to suction meconium from the airway. They leak at high ventilation pressures, they're ineffective when chest compressions are needed, and medications cannot be delivered through them, as with endotracheal tubes. In clinical practice, LMAs are being used for the administration of surfactant, but this information may not appear on the exam yet. Endotracheal intubation is a core procedural skill. Indications include failed bag mask ventilation, need for mechanical ventilation, surfactant administration, diaphragmatic hernia, and upper airway obstruction. When I teach intubation, I always say that it is indicated for patients who cannot oxygen, ventilator, or protect their airway. There are two main approaches: oral and nasal. Oral intubation is faster and easier for emergencies, while nasal intubation may provide more stable tube positioning for long-term ventilation. Premedication should be considered for non-emergent intubations, typically including an analgesic, sedative, and sometimes a neuromuscular blocking agent called rapid sequence intubation, or RSI. The exam may ask about the indications for intubation and the appropriate use of premedication, particularly that emergency situations may not allow time for medication administration. There is usually a few questions about equipment selection for intubation. Laryngoscope blade size and endotracheal tube size correlate with infant weight. The exam usually asks a straightforward question about appropriate equipment sizing based on an infant's weight or gestational age, so it is important to memorize this information. Proper endotracheal tube placement is critical and frequently tested. There are several methods to determine insertion depth: the nasal tragus length plus 1 centimeter, or the weight in kilograms plus 6 centimeters. Confirmation of placement requires multiple methods. An end-tidal CO2 detector should show color change indicating CO2 in exhaled air. Auscultation should reveal bilateral breath sounds, and a chest X-ray provides definitive confirmation. Complications of intubation include hypoxia, bradycardia, airway damage, tube misplacement, and accidental extubation. The exam may present scenarios where you need to recognize complications and determine appropriate management, such as identifying a right mainstem bronchus intubation based on absent left-sided breath sounds, or which is the best or quickest method for confirming tube placement. Thoracentesis is performed to relieve pneumothorax or evacuate pleural fluid. The technique varies slightly depending on what you're draining. For needle aspiration of a pneumothorax, insert an 18 to 20 gauge angiocatheter at a 45-degree angle in the 2nd, 4th, or 5th intercostal space at the midclavicular line. Then, decrease to a 15-degree angle once the catheter enters the pleural space. For chest tube placement, the most common site is the 5th intercostal space at the mid-axillary line. Position the infant with the affected side elevated 60 to 75 degrees from the bed to allow air to rise for easier aspiration. For air collections, position the tip anteromedial. For fluid collections, position the tip posteriorly. The exam may ask you questions asking to identify the landmarks or equipment needed for this procedure. Umbilical vessel catheterization requires knowledge of specific anatomical landmarks. The umbilical vein is a single, thin-walled vessel typically located at the 12 o'clock position in the umbilical cord. The two umbilical arteries are thick-walled vessels usually found at the 4 and 8 o'clock positions. Catheter size selection is based on infant weight. Use a 3.5 French catheter for infants under 1,500 to 2,000 grams and a 5 French catheter for larger infants. Common indications for umbilical artery catheterization include frequent arterial blood sampling, continuous blood gas monitoring, and blood pressure monitoring. Umbilical venous catheters are used for emergency medication administration, fluid resuscitation, and central venous pressure monitoring. The exam may test these anatomical landmarks and proper catheter selection. Proper catheter placement is crucial. For umbilical artery catheters, there are two acceptable positions: high position between the 6th and 10th thoracic vertebrae, T6, T10, or low position between the 3rd and 4th lumbar vertebrae, L3, L4. For umbilical venous catheters, UVCs, proper placement is 0.5 to 2 centimeters above the diaphragm at the level of T8, T9. Never advance the catheter once it's secured, as this introduces the risk of infection. Complications include thrombosis, embolism, vessel perforation, infection, and vasospasm leading to blanching of the extremities. Malposition can cause hypertension, renal ischemia, or necrotizing enterocolitis. Peripheral arterial catheterization is indicated when frequent blood sampling is needed, but umbilical access isn't available, when continuous blood pressure monitoring is necessary, or when pre-ductal measurements are required. The Allen test must be performed before radial artery cannulation to ensure adequate collateral circulation through the ulnar artery. A modified Allen test is used for dorsalis pedis or posterior tibial cannulation. The technique involves inserting the catheter at a 10 to 15 degree angle with the bevel down, or at a 30 to 40 degree angle with the bevel up. Complications include arteriospasm, thrombosis, and tissue damage. Central venous access via PICC or midline catheters is indicated for long-term IV therapy, parenteral nutrition, difficult venous access, or administration of irritating medications. Proper tip placement depends on the insertion site. In upper extremity insertions, the tip should be in the superior vena cava. In lower extremity insertions, the tip should be above the L4-L5 vertebrae. Preferred insertion sites include the basilic and cephalic veins. The exam often tests complications of central lines, including infection, thrombosis, catheter migration, cardiac arrhythmias, and tamponade. Understanding the risk factors and prevention strategies for these complications is essential. Cardiopulmonary monitoring is a basic but essential aspect of neonatal care. ECG electrodes are typically placed with the white electrode on the right mid-clavicle, the black electrode on the left mid-clavicle, and the red electrode on the left lower abdomen. Standard alarm parameters include bradycardia below 100 beats per minute, tachycardia above 180 beats per minute, and apnea typically set at 15 to 20 seconds. Limitations of monitoring include motion artifact and false alarms, which can lead to alarm fatigue. Proper skin preparation and electrode placement help minimize these issues. The exam may test your knowledge of normal vital sign parameters for neonates of different gestational ages, and your ability to troubleshoot common monitoring problems. Pulse oximetry is one of the most common monitoring techniques. It works by measuring the differential absorption of light between oxygenated and deoxygenated hemoglobin. It's important to understand that pulse oximetry measures oxygen saturation, not partial pressure of oxygen. Uses include continuous oxygenation monitoring, critical congenital heart disease screening by comparing pre-ductal and post-ductal measurements, and titrating oxygen therapy. Key limitations include poor accuracy during poor perfusion states, motion artifact, and reduced reliability at very high, greater than 97%, or very low, less than 70% saturations. The exam may test these principles and the clinical applications of pulse oximetry, particularly its role in CCHD screening protocols. Transcutaneous monitoring provides continuous estimation of blood gases through the skin. For transcutaneous PCO2, the sensor heats the skin to enhance gas diffusion, but the values typically overestimate the actual PaCO2. For transcutaneous PO2, heating causes local vasodilation, making skin PO2 approach arterial PO2, though it usually underestimates the actual PaO2. Limitations include the need for frequent recalibration, risk of thermal burns from prolonged sensor placement, and decreased accuracy with poor perfusion, edema, or thick skin. Transcutaneous monitoring is most useful for trending rather than absolute values, particularly when initiating high-frequency ventilation, where rapid changes in CO2 levels need close monitoring. Near-infrared spectroscopy measures regional tissue oxygenation and is increasingly used in NICUs. It works by using light in the near-infrared spectrum to penetrate tissues and measure the differential absorption between oxygenated and deoxygenated hemoglobin. NIRS provides a regional oxygen saturation value, reflecting the balance between oxygen delivery and consumption in specific tissues. Common applications include monitoring cerebral oxygenation during cardiac surgery, assessing the hemodynamic significance of a patent ductus arteriosus, and guiding management of hypotension. Limitations include variation in values depending on metabolic state and the inability to precisely determine venous saturation. The exam may test your understanding of when NIRS provides valuable clinical information versus when its limitations make it less useful. End-tidal CO2 monitoring, or capnography, measures exhaled CO2 and comes in two forms. Mainstream monitors have the sensor directly in the ventilator circuit, while side stream monitors divert a small sample of gas to a remote sensor. Primary uses include confirming endotracheal tube placement. A color change on the detector confirms tracheal rather than esophageal intubation, monitoring ventilation effectiveness, and guiding respiratory management. Limitations include poor reliability with high-frequency ventilation and inaccurate estimates in severe lung disease, where ventilation perfusion matching is disrupted. Blood gas monitoring remains the gold standard for assessing oxygenation, ventilation, and acid-base status. Invasive monitoring via umbilical artery catheters or peripheral arterial lines provides the most accurate data. Remember that blood gases from umbilical catheters reflect postductal blood. Non-invasive alternatives include pulse oximetry, transcutaneous monitoring, end-tidal CO2, and near-infrared spectroscopy, each with specific strengths and limitations. The exam may test your ability to interpret blood gas results in various clinical scenarios, particularly your understanding of compensatory mechanisms in metabolic and respiratory disorders, and when to rely on arterial versus capillary samples. Thermal regulation equipment includes incubators and radiant warmers. Incubators provide an enclosed environment with heated air and can operate in skin servo-control mode, adjusts based on the infant's skin temperature, or air servo-control mode, maintains a set air temperature. Double-walled incubators reduce radiant heat loss and provide more stable thermal environments. Radiant warmers use infrared energy to heat the infant's skin and can be servo-controlled or manually controlled. They provide better access, but increase insensible water loss. The exam tests your knowledge of appropriate temperature settings, weaning protocols, no faster than 0.5 degrees Celsius per 30 minutes or 1 degree Celsius per hour, and recognition of thermal regulation equipment malfunctions. Phototherapy is the primary intervention for hyperbilirubinemia and works by using light energy to convert bilirubin into water-soluble isomers that can be excreted without conjugation. Effectiveness depends on two key factors: the irradiance, energy output, of the light, and the amount of skin surface area exposed. The optimal wavelength range is 450 to 475 nanometers in the blue-green spectrum. Types of phototherapy units include fluorescent tubes, halogen spotlights, fiber optic systems, and LEDs. The neo-blue LED system is particularly effective due to high spectral irradiance with minimal heat generation. The desired irradiance is 10 to 40. The exam frequently tests phototherapy principles, indications based on bilirubin levels and risk factors, and management of complications like increased insensible water loss. Certain diagnostic tests are consistently associated with specific conditions on the exam. The hyperoxia test is used to distinguish cardiac from pulmonary causes of cyanosis. If PaO2 rises above 150 millimeters of mercury with 100% oxygen, cyanotic heart disease is unlikely. The sweat chloride test is the gold standard for cystic fibrosis diagnosis. Cholangiogram is definitive for biliary atresia. The Kleihauer-Betke test quantifies fetal-maternal hemorrhage. For polycythemia, a central hematocrit above 65% with symptoms or above 70% without symptoms indicates the need for partial exchange transfusion. Forelimb blood pressure measurement is essential when coarctation of the aorta is suspected, showing higher pressures in the upper extremities compared to lower extremities. Let's wrap up by highlighting the most critical concepts for the exam. Laboratory tests provide essential diagnostic information, but judicious use is necessary given neonates' limited blood volumes. Radiographic interpretation, particularly chest X-rays showing respiratory disease patterns, is heavily tested. Know the proper positioning of tubes and lines on X-rays. Understand which diagnostic study is most appropriate for specific clinical questions. Ultrasound for initial brain and renal imaging, MRI for detailed neurologic evaluation, upper GI series for suspected malrotation, and echocardiography for congenital heart disease. Remember, normal lab values for neonates differ from adults and vary by gestational age. Finally, integrate lab and diagnostic findings with the clinical presentation for effective clinical decision-making. A chest X-ray of a term infant shows diffuse reticulogranular pattern with air bronchograms and decreased lung volumes. These findings are most consistent with meconium aspiration syndrome, pneumonia, respiratory distress syndrome. This question is testing your ability to recognize classic radiographic patterns of neonatal respiratory conditions. The correct choice is respiratory distress syndrome. This is correct because the classic radiographic findings of RDS include a diffuse reticulogranular ground glass pattern with air bronchograms and decreased lung volumes. These findings reflect diffuse microatelectasis due to surfactant deficiency, which is the pathophysiology of RDS. Meconium aspiration syndrome is incorrect because MAS typically shows hyperinflation with patchy, coarse infiltrates and areas of consolidation alternating with areas of hyperinflation, not the diffuse pattern described. Pneumonia is incorrect because while pneumonia can show consolidation and air bronchograms, it typically appears more patchy or lobar rather than the diffuse pattern characteristic of RDS. A term infant presents with irritability, jitteriness, and a prolonged QT interval on ECG. Laboratory analysis would most likely reveal hyperkalemia, hypocalcemia, hyponatremia. This question is testing your knowledge of electrolyte abnormalities and their clinical manifestations, particularly cardiac effects. The correct choice is hypocalcemia. This is correct because hypocalcemia classically presents with neuromuscular irritability, jitteriness, seizures, and prolongation of the QT interval on ECG. This is a common electrolyte abnormality in neonates, particularly in infants of diabetic mothers, preterm infants, and those with birth asphyxia. Hyperkalemia is incorrect because it causes different ECG changes, primarily peaked T waves initially, followed by widened QRS complexes and ventricular arrhythmias in severe cases, not QT prolongation. Hyponatremia is incorrect because while it can cause irritability and seizures, it does not typically cause QT prolongation on ECG. A preterm infant has an umbilical venous catheter, UVC, inserted. On X-ray, the tip of the catheter is visualized at the level of the diaphragm. This position is acceptable and should be maintained, too low and should be advanced, too high and should be withdrawn. This question is testing your knowledge of proper placement of umbilical lines as visualized on radiographs. The correct choice is too low and should be advanced. This is correct because proper UVC placement should be 0.5 to 2 centimeters above the diaphragm at approximately T8 to T9, at the junction of the inferior vena cava and the right atrium. A UVC at the level of the diaphragm is too low and risks being in the portal venous system rather than the central circulation. Acceptable and should be maintained is incorrect because this position does not represent proper central placement. Too high and should be withdrawn is incorrect because the catheter is actually not high enough for proper central placement, which would be above the diaphragm. An infant with a central hematocrit of 68% is showing lethargy and poor feeding. The most appropriate initial intervention is fresh frozen plasma transfusion, partial exchange transfusion, whole blood transfusion. This question is testing your knowledge of polycythemia management in neonates. The correct choice is partial exchange transfusion. This is correct because symptomatic polycythemia, central hematocrit inglated to 65% with symptoms, is managed with partial exchange transfusion to reduce blood viscosity, improve microcirculation, and alleviate symptoms. The procedure typically uses normal saline to replace removed blood, reducing the hematocrit to approximately 50 to 55%. Fresh frozen plasma transfusion is incorrect because FFP would not reduce the hematocrit and could actually worsen the hyperviscosity. Whole blood transfusion is incorrect because adding more blood components would worsen polycythemia rather than treat it. A neonate with suspected bacterial sepsis has a C-reactive protein, CRP level, that is normal on initial testing. The most appropriate next step in laboratory monitoring is order a lumbar puncture immediately, repeat CRP measurement in 24 hours, switch to procalcitonin measurement. The correct choice is repeat CRP measurement in 24 hours. This is correct because CRP has low sensitivity, about 60%, in the initial phase of infection. It typically rises 6 to 8 hours after the onset of infection and peaks at 24 to 48 hours. Serial measurements significantly improve diagnostic accuracy and are more valuable than a single determination. Order a lumbar puncture immediately is incorrect, because while an LP may be indicated in the evaluation of sepsis, a normal initial CRP alone doesn't dictate this decision. Clinical assessment and other laboratory findings would guide this. Switch to procalcitonin measurement is incorrect, because while procalcitonin rises faster than CRP, there's value in following the trend of a single inflammatory marker rather than switching between different tests, and both tests can be useful but have different kinetics.